All right. Thank you everyone for joining our webinar entitled Sex and Drugs, Integrating Reproductive and Sexual Health Services in OUD Treatment. Again, I encourage you to put your name and email address in the chat so that we can send you information and also know who's joining us. Our presenter, Dr. Jonathan Stoltman, is director of the Opioid Policy Institute. In 2019, he completed his PhD in lifespan developmental psychology from West Virginia University. During his doctoral training, Jonathan completed research at West Virginia's leading opioid treatment facility, the Koch Clinic at WVU. He received CTSI funding for his dissertation work on reproductive and sexual health service knowledge, access, interest during opioid addiction treatment. And this work is graciously supported by his mentors, Dr. Andre Jones, Dr. Mishka Turplan, and Laura Lander. Jonathan's research manuscripts have appeared in leading journals such as Drug and Alcohol Dependence, Addictive Behaviors, and Experimental and Clinical Psychopharmacology. Additionally, he has presented research at national and regional conferences since 2013. Currently, he is leading two initiatives through the Opioid Policy Institute. First, a review of the privacy security practices of OUD treatment acts, and second, an effort to reduce addiction-related stigma and discrimination by helping improve how the media covers addiction. And so with that, I will turn it over to you, Dr. Stoltman.
Thank you, Angie. Really glad to be here today with the Michigan Opioid Collaborative, and we'll jump into the talk. Thank you to Dr. Kara Poland from Michigan State for setting this all up, and Ashley and Angie at the Michigan Opioid Collaborative for helping out, especially with rescheduling. As you know, we lost power a couple weeks ago, so I'm happy you could all join us today. And we're going to do our talk on integrating reproductive and sexual health services in OUD treatment. Sometimes it's referred to as sexual and reproductive health, but I prefer the alphabetical version, reproductive and sexual health. So we'll start here with our conflicts. I don't have any conflicts, but of course I have a lot of interest in reproductive and sexual health and addiction and integrating care. The learning objectives for today are to learn about reproductive and sexual health service umbrella, understand the intersection of reproductive and sexual health and opioid use disorder treatment, and then learning how to integrate the two. So we'll start with our framework here, and we know that addiction treatment overall includes a number of aspects of well-being, including spiritual, emotional, social, physical, and cognitive health. And what we're gonna talk through today is how reproductive and sexual health is really a big part of overall well-being, and it's one of the things that's commonly missing from the model and commonly missing from treatment as well. And as you can tell here, reproductive and sexual health actually hits on a number of different parts of well-being, from emotional, social, and physical health. And so it is really important to figure out how to integrate these services in your current treatment and practice. So from a high level, what is reproductive and sexual health? So reproductive health is addressing reproductive processes, specifically function and system, and it's at all stages of the lifespan. And so one example of this is contraceptive counseling, which is what a lot of our talk will today focus on, because that's what a lot of the research is in. And I think one of the easiest ways to start to integrate reproductive and sexual health care. And it's usually where it stops in current treatment settings. So we don't have a ton of research on integrating sexual health care, but we do think the full model is the most important and most holistic approach. And so sexual health is that state of physical, mental, and social well-being in relation to sexuality and sexual functioning. And so what we're recognizing is that RSH is a key component of holistic medicine, and that integrating these services is often lacking in OUD treatment outside of the needs of pregnant women. So what we will talk about today is some of the research specific to pregnant women, but what I would hope people keep in mind is that we want to think broader about reproductive and sexual health and how that fits into the overall framework. So this is a great model from the WHO. It is not great on a slide, but I will talk through it a little bit, and hopefully the slides are distributed afterwards. So if you're interested, you can really dive in and unpack it. And so what we want to think about when we think about RSH from a framework perspective is that it is a holistic approach. So in integrating this in opioid use disorder treatment, we want to try to integrate as many of these components as possible. It's also important to recognize that our reproductive and sexual health are both linked. So doing one without the other is a challenge for both the patients and a provider perspective. When integrating reproductive and sexual health, it's important to protect and respect human rights and choice. And we'll talk a little bit about how to do that when trying to integrate these services. And then it's also important to recognize that there are really diverse needs across both the lifespan and the different populations that we're serving. And so there's not really a one size fits all approach. It's important to keep that in mind when developing these services. And also, of course, the need for evidence-based approaches. There are a number of really great research studies specific to OUD that we'll talk about and how to integrate contraceptive counseling. And it's, of course, important to reference that literature before trying to integrate these services into your own clinic. So at a high level, why RSH and OUD? Men and women with opioid use disorders have high rates of adverse reproductive and sexual health outcomes. So for example, about 90% of pregnancies among women in treatment for opioid use disorder are unintended. And I'll say that again, 90% of the pregnancies among women in treatment for opioid use disorder is unintended. The general population, that's about 50%, so almost double the rate, and it means that we have a lot of work to do when we think about integrating these services into OUD care. Screening for STIs and STDs are important. There are higher rates. Overall, it's rising nationally, the rates of STIs and STDs, but there's generally higher rates in OUD treatment clinics, the few studies that have been done. When we think about contraceptive efficacy, the most common approaches, unfortunately, are the low efficacy approaches. And so that can be a challenge when we think about how that ties in with unintended pregnancies. And then at the end of the day, the best approach is still considered dual use, which is a condom plus another approach, because the condoms are still vital in preventing STI, STD, and HIV. But there are a number of issues with condoms, even though they are the most common approach. And we'll talk a little bit about that later as well. Erectile dysfunction is an interesting one, really very rarely talked about in a treatment setting, but rates of erectile dysfunction among men in treatment for opioid use disorder are fairly high. It's about 20 to 30% of the samples that have been studied. And it's actually a little bit higher with methadone compared to buprenorphine, which is that difference between that full agonist and the partial agonist. So there are some theories about why that is indeed the case. But when we think about reproductive and sexual health services overall, that's why it's important to consider both men and women and overall sexual functioning. And then lastly, low libido is thought to be a side effect of the different treatments, and also the experience of trauma and psychiatric comorbidities. So when we think about focusing on reproductive health, which is typically what we do with contraceptive counseling, there's also that range of sexual wellness and well-being, and libido is a really big factor of that. And so now that we know that it's lower in these samples, it's important to try to talk to patients about those issues so that we can address them. And at the end of the day, patients want co-located / integrated reproductive sexual health services with their addiction treatment. And that's a really important point. This is not just an academic exercise, and we think that they would benefit from these services. Really, when asked, they do want these services co-located or integrated, and we'll talk a little bit about how that may be done. But at the studies that have been done, and the one that's the most comprehensive has been done in North Carolina by Clayman et al. In 2019, and showed that less than 50% of the facilities do have integrated care, even though patients want it, and even clinic directors want it. So we'll talk through some of the challenges for how to integrate this. So you might be thinking right now, how does all of this concern me? I'm really focused on their opioid use disorder, and that's hard enough. So why put this reproductive and sexual health work on me? But when we take a step back, when they're actually accessing opioid use disorder treatment, we know that it's really important to integrate reproductive health and sexual health services, not just because patients want it, but because they've gotten through the many, many barriers that are accessing treatment and care in our country. So we need to recognize that there are some hurdles just even to get in the door. And so once they're in front of you, doing whatever we can as providers is going to be really important. So some of the barriers they might face are these provider barriers, such as stigma. We know well that as in the state of Michigan still, even though there's been great strides to resolve this, there's training deficits in expert practices, and then just a general lack of addiction treatment specialists. I'm always still surprised when I look at the map of the Upper Peninsula and just how hard it is to get access to care. There's also those institutional barriers like the limits for integrated care, and that can come down to insurance and other practical issues. And then regulatory and legal and financial barriers that make it really hard for incarcerated individuals or mental health parity to even be enforced in our country. So we have a lot of work to do overall with barriers, but now they've made it through. And pregnant women in particular, which is a great study from Stephen Patrick's group down in Vanderbilt. He's a former Wolverine as well. And they looked at the secret shopper study back a couple of years ago, and they did it in 10 states with a phone bank. Michigan was one of the states. And so there was calls done by women 25 to 30 years old, and they were randomly assigned a pregnancy status. And pregnant women had a number of barriers. And so the call process itself was identified as a barrier. So just getting through on the phone to a live person to try to schedule an appointment was really challenging. And even just on the first call, does the first call result in an appointment? And less than 50% of the time, that's a yes. Stigma, of course, the disparaging comments made by the people that were answering the phone, and then just the lack of refusal for why treatment was not provided or not accessible to that caller. There's also those disparaging comments that people face frequently, such as criticism if it's a pregnant woman that's seeking care, like, why aren't you just stopping using drugs, for example. Abruptness, rude, patronizing language and tone. So they were able to analyze all of that. And I don't think it's surprising to this audience, but it is still really disturbing that people calling for treatment can face these barriers like this. And then, of course, eligibility concerns like insurance. Some places didn't offer cash. Some people would say that you don't have the correct type of insurance, or they're not taking new patients, long wait lists, eligibility barriers. And this is before COVID. We know COVID has really amplified all of these things and made it a lot worse. So now the patient has gone through that gauntlet and gone through all of the barriers and the maze that is entering opioid use disorder treatment in our country still, and they've arrived at your clinic. And so I hope that shows you that, with all of the work that they've done and their interest in integrated care, that's kind of why we think that this is an important audience to provide these services. So why me? I love this piece by Tricia Wright in 2019, and it really explains why providers in particular, addiction providers in particular, are the perfect people to provide reproductive and sexual health counseling. So one of the reasons is that skill set that providers have in motivational interviewing, and reproductive and sexual health counseling is a really collaborative process. So you can use a lot of those same skills, they're transferable. Providers, and I hope that you've experienced this, have a really strong relationship with their patients because of that gauntlet that they've gone through. So they've been denied treatment or care at a number of different places. They finally got through to you as a provider. And so they have that strong relationship, and they do feel like you're someone that can actually help them. Addiction treatment and opioid use disorder treatment in particular is longitudinal. So most of the time we're seeing those patients over a number of different time points, over a number of different years. So providing that full range of services can be really important. And then non-judgmental and non-coercive care is the standard in addiction care. So it's really coming at it from, again, a person-centered approach. So we would argue that, addiction treatment providers are the perfect and ideal person to provide this reproductive and sexual health counseling. In terms of another reason why, in particular, addiction treatment's important with addiction treatment integration with reproductive sexual health is it's a key component of relapse prevention. So pregnancy can be a motivating reason to seek treatment. So some of the clinics that you're involved in, you might notice that you have a number of pregnant women and that's their first interaction. And so it's really important to then leverage some of that motivation in seeking treatment to also provide them some of these additional services. Clinics also frequently get referrals for pregnant women. And postpartum is a challenging period because of the stress, that gap in insurance coverage, and then the risk of postpartum depression. But during that whole time period, they're still interacting with their opioid use disorder treatment provider if they're staying up in treatment. And so you have an opportunity to make an impact in those different areas. It's also important to keep in mind that well-spaced interpregnancy intervals are important to the overall health of the dyad, and that there are gaps in follow-up with OBGYN care traditionally. And so we think that OUD treatment providers can fill some of that gap. So there's those additional appointments that you do postpartum, that the show rate is a little bit lower in opioid use disorder patients. And so can we, as a clinic, provide some of those additional services and fill that gap? So this is not to say that it's easy, unfortunately, to integrate RSH in your current setup. So we're going to talk through some of the barriers and facilitators towards doing this. In terms of barriers, I'm sure you're all thinking through some of these already. If you're interested in providing reproductive health services, which I hope you are if you're on this call, but you're kind of racking your brain for, well, how do I do this stuff? So there's that lack of equipment, there's that lack of supplies and space, which is just inherent in any medical system, unfortunately. Challenges with staff time and training. So there's already a number of different issues that the staff is working on, and they might not have that specific training that we're going to talk through that's important for ethical contraceptive counseling. It's often identified that there's a need for childcare to provide some of these more in-depth services. And then challenges around reimbursement and insurance issues. The competing priorities that is addiction treatment care, because addiction does affect the whole person, trying to figure out how reproductive and sexual health prioritizes for that patient in your treatment goals is going to be really important. There's also a lot of stigma around pregnant women, even in treatment clinics. And so addressing that and really recognizing, how that might enforce or how that might influence your level of care. And then the fear of law enforcement and CPS can't be understated. There are concerns that if provisions are provided for pregnant women, for example, that you kind of get caught up in this CPS law enforcement loop, and that can be really challenging. However, there's also a number of facilitators, such as reprioritizing reproductive and sexual health services. What we have found in the data is that, as we said before, patients are really interested in these services. So if you make them available and make them widely known, we're pretty confident that patients will slowly start to take advantage of them. Providing transportation can be really important towards helping people access reproductive and sexual health services once they have identified that as an area of need. And so that's can be challenging, especially if the clinic is separate from other facilities in the medical system, as is often the case. So providing that transportation and that linkage to care is really important. Of course, having insurance coverage and advocacy work around providing insurance coverage for the full RSH spectrum. The funding of services, if you can secure funding specific for these things, of course, that can facilitate their use, and then providing training and education. So how does it look in your clinic? These are some of the different areas that fall under that RSH umbrella that can be really important to OUD treatment and care. And so integrating some of these services is a step towards really fulfilling that holistic goal of providing whole person care. So education is really important, providing accurate and evidence-based STI, HIV, and pregnancy prevention education, providing education about safer sex options and pregnancy options, such as the Plan B pill. Screening and testing should be made available for pregnancy, HIV, HCV, and HBV, STI, STDs, cervical cancer, Pap screenings, and trauma/interpersonal violence. All of that can be done fairly easily in the current clinic settings, but you also need to be prepared, for example, with the trauma screen for how to handle that information. So it doesn't make sense just to, start adding a bunch of screeners without providing all of the structure around it. Additionally, family planning services such as access to contraceptives like long-acting reversible or LARCs, prescription and non-prescription methods. And one of the research-based really important approaches is that same-day contraceptive initiation. So if a patient says, hey, I'm interested in using an intrauterine device or IUD, being able to provide that the same day is really important to overall uptake. Next, setting up clear referral channels for prenatal care if your clinic's not situated to provide that, and making sure that there are those warm handoffs between providers. Treatment for HIV, Hep C, STIs, and STDs, and then trauma counseling if that's outside the scope of your current practice. And then lastly, providing vaccinations such as Hep B and Hep V. So one of the ways now that we're starting to think about integrating these services, it's also going to be really important. I hope that you saw on that list that there are some maybe low-hanging fruit that you can start to implement in the next 6 months, for example. It's also going to be really important to keep quality indicators of the reproductive services that you're offering. So one of the big quality indicators is making sure that men and women have the ability to make that informed choice. And so it's not just providing education, it is making sure that when they do make a choice to implement reproductive or contraceptive care, that they know indeed what the side effects are and the potential options. Also, having sexual actions that are based on intention and a substantial understanding of coercion, discrimination, and violence. And so helping patients understand when they or see the signs of an abusive relationship, for example, so that they can know when they're in a coercive sort of environment or identify ways to help them out of a violent partner. Then satisfaction with one's sexuality and sexual identity. All of these are measurable and really important to measure as quality indicators to see how implementation of these services is indeed increasing access to care. The next is the availability of services, so the breadth of services that are available in that list that I had just provided, making sure that you're starting to check through, hey, are we offering this, this, and this, and kind of keeping an eye on how can we increase availability of the services that fall under reproductive and sexual health care, fall under our ability to provide them and our patients' interest in them. And then the proportion of the population that's received reproductive and sexual health counseling, so that's that education component and making sure that you're reaching all of the patients that you can. Our research has shown, which we won't get into today, I didn't think we would have time, but in West Virginia, when I was down there a couple of years ago, the knowledge around the higher efficacy and newer approaches to reproductive and sexual health counseling was severely deficient. So providing that RSH counseling that includes some of these newer techniques and talk through, you can't just assume that patients know all of the different approaches. And so that also ties in with that awareness and use of RSH services. So at this point in the talk, typically folks throw up their hands and say, well, we offer condoms. And one of the ways that we typically offer condoms that I like to talk about is that fishbowl of condoms. These are actually kind of a disturbing image, but these are the KISS condoms. And this is obviously not an endorsement of KISS condoms, but part of what you'll see, especially in harm reduction services, is, they'll just throw a bucket of condoms on the counter, and then that checks their box for providing reproductive and sexual health services. But as you can tell from this talk thus far, that's nowhere near adequate, even though it is really common, and it's not a great example of quality care. On the right here is an image of individuals which you might have remembered from 2018. There was a Southwest Airlines flight that they had an engine malfunction. And during the engine malfunction, there was a selfie taken on the plane. And with the selfie, you'll notice that no one in the image, unfortunately, is actually using the mask the right way. This applies to condoms too. Condoms are actually a lot more complicated than we give them credit for, and using them properly is a series of steps that are really important. So the mask example is a simple and silly one, but we've heard if you've flown on a plane in the last 20, 30 years, they go through those very basic instructions. And, it's a really simple set of steps. It's just covering your mouth and nose. And you can tell during a time of stress or, awareness of the situation, it's kind of a tense situation, nobody's able to follow through. Condoms are almost the exact same thing, unfortunately. So the bucket of condoms, if that was your plan after listening to this talk, I hate to break it to you, but that's just not going to cut it. So this is the 10 steps of condom use. I'm not going to go through each of the steps, but I think this illustrates nicely that it's not just as simple as throwing a bucket out and saying like, hey, just start using condoms and everything's going to be okay. It doesn't equal comprehensive counseling. It doesn't even equal just general reproductive and sexual health services. If you, for example, provided education components with the condoms, that's a good step, but still not comprehensive. So again, we're not going to go through this. If you're interested in or didn't believe me that there were indeed 10 steps to condom use, it is fairly complicated. And that's a reason why there are high failure rates, and also why we'd like to see clinics do better. So how do we get started if it's not just throwing a bucket of condoms on the counter? One of the great ways to do this is called the One Key Question. And this is a tool that's been developed by onekeyquestion.org, and it's been supported by the American Public Health Association, ACOG, and the AMA. And there's a series of certifications and partnerships that are available if you in your clinic is interested in it. And it's a really simple approach. It's just asking a patient either during intake or early during their time in the clinic, would you like to get pregnant in the next year? That opens the door to a collaborative patient-directed conversation about their reproductive goals. And so, what we've seen in our research is oftentimes the answer is no. I'm not interested in being pregnant in the next year. And typically you'll see that, especially with people that are just starting treatment. They just kind of want to, get in the groove of this new healthier lifestyle. And so they are trying to not get pregnant in the next year, but they don't know what their options are. And so that's how it can lead you into a fuller discussion that's both patient directive and collaborative about the different options that are available. So one key question is a really powerful approach. It's much more complicated than I've made it seem on this slide, but the certification is a really great process for individuals. It's also important to keep in mind when talking about contraceptive counseling that one of the things that's really hot in the opioid use disorder treatment space and intersection with reproductive sexual health is LARCs, those long-acting reversible contraceptives. And there's a good reason why. So they're really effective or highly effective. There's a couple different types, the IUDs or intrauterine devices and implants. An IUD, you can see in the image to the right, it's that T-shaped device. Implants are usually little rods that are implanted into the upper forearm or upper arm area. And they can last anywhere from 5 to 10 years. What's really important is that they're reversible. So for patients, that preserves their autonomy. And what we have found and others have found with their data in opioid use disorder treatment clinics, women that use IUDs generally like them. They don't have a ton of side effects in the small samples that have been looked at, which is important to keep in mind. It is a small sample and there are side effects associated with LARCs and they do need to be monitored. But most of the women that have been assessed that have started using them do really like them, but beforehand didn't know that they were available as an option because it is a fairly new approach. And unfortunately in our country, we don't do a super great job of educating about reproductive and sexual health in school. So not terribly surprising. It's great that they can last 5 to 10 years and they are reversible. So I've heard patients that talk about, it's really powerful because I don't intend to have a kid right now. I'd love to get through the next year or two and then think about that with my partner. And so the LARC allows them to get through that next year or two with a highly efficacious approach that is then reversible when they are ready to have children. It's important to note that the LARCs are only available for women. And it's also really important to consider that there is a strong history, unsurprisingly, of coercive contraceptive use. So it's important if doing consultation around LARCs or any contraceptives in general, that you keep in mind those power dynamics. You avoid any mandates or incentives. And I'm going to talk a little bit about incentives on the next slide, and structuring the incentives in a way that isn't for getting a certain contraception or a certain approach is really important and has been recognized by a number of national groups, including the ACOG and AMA. Oh, am I still? Yeah, sorry, it said I was signed up. And so offering that range of contraceptive options that is non-coercive. And so it's important to ensure patient autonomy and then also ensuring that there's contraceptive equity. So making sure that these options are presented to all of the patients in your clinic that they are available for. So all the women in your clinic, for example. There's not any one size fits all approach for any contraceptive counseling. And so it's important not to think about it in that way and provide just a set series of options. And so we need to reduce barriers to care, of course. Like I said before, that same day initiation is really, really important, and that there's no obstacles and there's no judgment offered during the consultation. And that these high efficacy approaches aren't the only focus of contraceptive counseling. So one of the issues that has been identified is, especially since patients don't know about the high efficacy ones, when clinics start to do consultation, they really focus on and provide a bunch of information about them and talk less about some of the other options. And so that can be seen as coercive and doesn't provide that full range of options and issues about contraceptive knowledge. Again, it's totally understandable why there's the enthusiasm that there is around the high efficacy approaches. They're really exciting. They're new, lower levels generally of side effects and reversible, which is really powerful. But keeping those things in mind can also bias those conversations about the approaches. So one of the ways to avoid this is to do alphabetical presentation of the approaches as opposed to efficacy based. So that's considered to be a lot more neutral and something to keep in mind when you're integrating contraceptive counseling in your practice. So I did say incentives aren't great. But I will say that they can be used in a way that can be really powerful. It's just important how the incentives are integrated into care. So there's this awesome piece of research that came out this summer from Sarah Heil up at Vermont, and their group has been doing some incredible work on this for more than a decade. They've been really leading the edge on LARC implementation in opioid use disorder treatment. And so I was very excited when this piece came out, and they did 3 different groups for their intervention. The one was usual care, and the usual care group just got the traditional, here's a brochure and some contact information for a facility in the community that can provide it. Then there's the contraceptive services approach, which is a guide tool from the WHO to guide the discussion. It's one of those little flip boards that kind of walks you through how to do contraceptive counseling. And this was done traditionally by nurse practitioners in the framework of the study. And they discussed, whether the contraceptives aligned with their values and their preferences and their goals. So it's very person-centered approach and shared decision-making to help them choose a prescription method. The study focused on prescription methods. And they provided education then specific to the method that they were interested in. And they were provided it for free as paid for through the study. And so if somebody was interested in the patch, ring, pill, injection, IUD, or implant, that was available immediately the same day, either by the nurse practitioner or somebody else trained to provide those approaches. So that's a really powerful approach. And then what they had shown, well, we'll talk about that next slide, is contraceptive services. This is the enhanced version. So it's all of the same stuff in the contraceptive services approach. Plus they provided incentives specifically for appointment attendance. So again, important to clarify, they didn't provide incentives based on the uptake of contraceptions, or they weren't incentivizing specific contraception. All that they were incentivizing was attendance of the appointment. Okay. And so again, really important that it's focused on increasing attendance to the contraceptive counseling visits, and that avoids some of those issues around coercion and, trying to target women in treatment for opioid use disorder as needing contraceptive counseling and trying to incentivize, hey, you should use this one that's highly efficacious and will ensure that you don't have any children. That is a very problematic approach. The group in Vermont, led by Sarah, does a very deliberate and very thoughtful way of providing these services. So the incentives were, again, independent of that participant's choice around and any contraceptive use. So if they initiated the method and discontinued it or used a non-prescription method, they still earned their incentive if they attended all of their visits. So it's 13 visits over the course of 6 months. The first visit was $15 and it ratcheted it up each visit. And the reason why they did this is because, over the course of 6 months, that's an important marker, but also there are a series of checkups with some of these prescription methods. Excuse me. So they wanted to find out whether if they incentivized attending those appointments, they could increase, surveillance of some of those side effects, for example, that can be really important to identify early. The incentives were provided in the form of a gift card that was the participant's choice, and the maximum earning over the time period was $437. So pretty substantial amount of money, but it does start again fairly small and then ratchets up. So what are the effects? The group sizes are about 48 per group. And what you can see here in the slides or in the images provided, that contraceptive plus group pretty much across the board had what we would consider like a dose dependent effect. And so it's pretty powerful that you can provide those contraceptive plus counseling. So the UC is the usual care group, and that's the bar on the left typically. That contraceptive service is the middle group, and then contraceptive service plus incentives is the right group. And so what you can see here is contraceptive use at 6 months and 12 months was higher in the group that received contraceptive services plus incentives. Also increased the amount of individuals that are using the long acting or the LARCs that are reversible. Important again to note that those in particular were not incentivized. But what that's showing, we think, is that the pamphlet and just giving a list of phone numbers isn't enough to provide that education. So providing that structured WHO tool education that walks you through all of the different approaches can lead to higher use of the long-acting reversible ones. And then also, importantly, a reduction in unintended pregnancies in the sample that had the incentive group. So it's very exciting results again. Implementing this is going to be challenging in a number of clinics because of the incentive design, but they're doing a lot of work up there to show how it is cost effective to do these incentives, in the hopes that they can convince insurance companies to implement some of these sorts of approaches in a way that's done ethically and person-centered. So, and very exciting work that came out this summer. So what do we mean when we talk about person-centered contraceptive counseling? There are 3 different domains to consider when we think about that. It's that interpersonal connectedness with the provider, support for their decision, and providing adequate information. And as we talked about before, the interpersonal connection of addiction treatment providers is really high with their patients. So that's why, again, you're really well situated to have some of these conversations. And then, of course, if there's adequate information and training provided and done in a way that's not coercive. So person-centered care respects that individual as a person. It lets that individual guide the discussion and say what really matters about their birth control use. So for example, if as a provider, again, there's a lot of enthusiasm around LARCs. If they want something that they can pick and choose when they're using it, a LARC's not the best way to do that. So maybe a NuvaRing ring is, or sorry, a ring-based approach is, as opposed to an implant or an IUD. Additionally, condoms might be a better approach or more aligned with maybe some of their religious beliefs. Taking my preferences about birth control seriously. So if an individual has concerns about a specific birth control, not being dismissive about those concerns, of course, is really, really important. And, ultimately, our goal as providers is to help them reach their healthy endpoints. So really accepting where they're at and taking their preferences seriously is going to be an important step towards that. And then, of course, providing enough information to help them make the best decision. Like I've said a number of times, education in this country about contraceptives is not great. So it is our job to provide some of that more evidence-based information to patients when they're going through this decision-making process. So importantly, there's also this great role for recovery coaches that has been shown in the research. And this is specific to people in the perinatal period, so pregnant women, but it can also be an important component of care for other individuals in treatment. I do want to caveat this that while they can be very important advocates, what we've noticed in, just in clinical settings is sometimes we dump a lot of expectations on recovery coaches, and that's not necessarily fair if we don't provide them that support and training. And I think this research really showed that, importantly, that there are a number of challenges, including drawing those professional and personal boundaries and how emotionally triggering work can be. And so if we are going to use recovery coaches, keeping in mind that they are a very powerful asset and can really help pregnant women feel, that there's support for their care, that they can complement the current practices and they can develop safety and trust. And what was really interesting in this research by Olding this summer was that, pregnant women that were interviewed for it found the recovery coaches to be motivational and aspirational, because many of them were mothers themselves that had gone through similar processes. And so not only are they an advocate, but they're, a hope to reach these recovery goals and seeing that this is possible, even though, of course, being pregnant with an opioid use disorder can be very scary and very challenging for a number of women. So of course, it's important that if we're going to use recovery coaches, even though they can be really important for providing this additional supportive services, that we do it in a way that's equitable and that they are supported, that we're not just dumping a bunch of stuff on them. And if, for example, they're going to lead contraceptive counseling, making sure that they're trained fully to provide those types of resources is really important. Thinking about all of this, we're talking a lot about reproductive and sexual health. And I think it's important to keep in mind, of course, that when we're talking about opioid use disorder populations, anyone on this call knows that individuals that are in treatment have a history of PTSD and sexual physical abuse and neglect. So when we're thinking about integrating reproductive and sexual health care, that's why, again, it's really important to do it very deliberately. And what we like to talk about is doing it in a trauma-informed way. And this is derived from the SAMHSA tip. And there's a number of resources from SAMHSA about providing trauma-informed care that are really important to consider, especially when we think about just general opioid use disorder treatment, but specifically if we're also going to include reproductive and sexual health services, being prepared for some of these issues. So trauma-informed care is just that delivery of care that includes an understanding of trauma, awareness of the impact it can have across settings, the services, and the populations. So when we talk about services here, it's natural to think, these reproductive and sexual health services can be very personal questions. They can be very invasive. And even if you have that really strong rapport with your patient, it still can be challenging to, jump right into that if you're not doing it in a trauma-informed way. So I know we're going over a lot in this talk, like a lot. And I just wanted to provide a high level conversation about trauma-informed care. That could be its own whole conversation at another time. But I think these resources are great, and it's important to keep in mind, if we are enthusiastic after seeing this talk, it's not just going in tomorrow and starting to ask all of these one key question, for example. It's really important to consider the lived experience and trauma of the individuals that are receiving care. Briefly, how to provide trauma-informed care. It's a system-level approach. So it's not just something that you would do as an individual provider. It's something that you should try to change at a system level. And SAMHSA has developed these 4 R's, which is where you realize the widespread impact of the trauma and understand how it affects potential pathways to recovery. Being able to identify and recognize the signs and symptoms of trauma in both the system itself and the patients that you're providing. And then being able to respond fully by integrating trauma-informed policies, procedures, and practices, and then resisting re-traumatization. The policies, procedures, and practices is really important, and we'll talk about that a little bit more on the next slide. So one of the ways that you can have policies, procedures that avoid re-traumatization and make for a safer overall environment is providing women-centered opioid use disorder treatment and care. And Joshi, again, this summer also, there's a lot of great research coming out this summer, as it turns out, related to reproductive and sexual health services. And so these trauma-informed approaches are important when we're considering women-centered OUD treatment and care. And so sometimes this means, providing women-specific times or programs where women come in the afternoon. And so keeping in mind that they have higher rates of sexual trauma and abuse, maybe making sure that they're not in a group that's an integrated group if they're not comfortable with that, or providing separate doorways that they can come and go where they feel safe and they are, in a caring and nurturing environment. So at the end of the day, that's everybody's goal with OUD treatment and care, is to provide that nurturing environment. And by no means am I suggesting it's easy to restructure your whole program to make it women-centered. But I will say that generally women-centered services end up having much better outcomes, especially when they're co-located. So this means that co-located OBGYN, mental health, and pediatric care services, that access improvement can be really, really powerful for your individuals. Providing coordinated care. So what we mean by this is just interprofessional collaboration. So I'm sure there's a lot of different disciplines on this call. So making sure that, the physicians are talking to the community health workers or talking to the social workers and providing that full wraparound services. And then quality that is tied to specific parts of care. So availability of group care. The women in the studies that were looked at, it was a scoping review, really liked the availability of group care. They liked having women's groups that they could all talk about their issues together, which could be really powerful. Providing that continuity of care. So if somebody is in the prenatal period, making sure that you have additional support postpartum to really help that individual thrive. Joint decision-making between providers and the patients, and then a reduced stigma approach. Again, that's come up a number of times, but really not providing judgmental care and accepting the person where they're at in their recovery process, in their wants. There are a number of barriers to providing women-centered care, such as stigmatization and that risk of criminalization, or just the outright criminalization of drug use for many women in pregnancy, that can make implementing this challenging, but it's still worth exploring in your treatment clinic. When we think about reproductive sexual health services, women-centered care that provides access to OBGYNs and pediatric care starts to really fill out that full picture. So again, when we think about reproductive and sexual health services, there are a number of different domains that we can think about implementing in our practice: education options, screening and testing, family planning, referral, and various types of vaccination that are related to your reproductive and sexual health. And this is just a repeat of the slide before that, again, emphasizes there's a lot of different areas that we can, I'm sure, improve in your current practice that can both be really valuable to patients and providers to provide some of that holistic care. And although we spent a bunch of time on contraception because that's where a lot of the data is, so we're really focused on family planning, screening and testing and education across the board, and referrals to care are really important to integrate. So I do want to emphasize it's not sufficient just to integrate contraceptive counseling, but there is good data to suggest that integrating contraceptive counseling is a great step towards whole person reproductive and sexual health services. So in conclusion, as you can tell, hopefully, that reproductive and sexual health services are a really broad array of services that cover reproductive systems and overall sexual functioning. There are a number of issues with opioid use disorder that intersect with overall sexual functioning, like libido, like erectile dysfunction, like menstrual dysfunction, and then overall reproductive systems and making sure those are functioning as well. And when we think about that full framework of well-being, reproductive and sexual health is a huge component of that. So, and despite the unique needs of patients in opioid use disorder that we highlighted before, integrated access is still really lacking in opioid use disorder treatment care. So I hope this talk is a step towards at least the groups that are on this call thinking about integrating it and trying to make plans to do so. Wanted to emphasize again that patients face a ton of barriers when accessing evidence-based care, and everybody on this call knows that. But that again emphasizes why it's important, if you're a provider and they've made it through all of those barriers, to provide that holistic care, because it's asking a lot for them to then go seek that reproductive and sexual health services at another facility or even with a whole different set of visits. They've already made it through, they're there, they're with you, they're interested if you ask them, and there's easy ways to start those conversations. So again, y'all are really well positioned to provide that counseling, and it can be readily integrated. I don't want to overstate that and make it seem like it's easy, because then we're just going to go with the KISS condoms again and the fishbowl. But there are things that you can probably do in your practice in the next 6 months that would really be a huge step towards integrating care. So I did want to thank again Kara Poland for setting up this talk. My mentors that Angie mentioned, Andre Jones, Mishka Turpin, and Laura Lander, and encourage you to follow some of our work and our Twitter for whatever that's worth. And the Stigma Project, if you're interested in that, it's called Reporting on Addiction, and we're doing some work to try to change the narratives. So thank you all, and I think it's a good time for questions.
Please feel free to either unmute yourself and ask a question, or you can put it into the chat as well.
Angie, are you going to be watching the chat for me to make sure?
Yes.
You catch it? Okay, thank you.
While we're waiting for any questions, do you want to pull up that screen again that has the code, the QR code on there?
Oh, sure. Yes. Yeah, let me share.
I had a question. This is Bill Weiner talking, and I was wondering who pays for the patient to make their appointments, because we have that a problem with regular visits as well as with the patients being treated for opioid abuse disorders.
So are you saying who paid in that research study?
Yeah, how do you get money to pay the patient to come to their appointment, which they scheduled?
Sure. So in that case, that was funded by the National Institute on Drug Abuse. So the study, it built in as part of their grant, the paying for those services. However, a big part of the study, if you're interested in digging in a little deeper, was justifying those costs, because it is more cost effective to provide those incentives. And so they're doing a lot of work to try to show insurance companies that reimbursement for incentivized care can be an important step. But currently, as you know, incentives are not reimbursed, except for the VA does some incentive reimbursement for attendance of addiction treatment, but broadly across Medicaid, Medicare, and private insurance, typically those incentive systems aren't currently in place. So there is a movement to do so, but it's not quite there yet. Did that answer your question?
Yes, thank you. We had in the thumb of Michigan, great improvement in vaccinations when we gave out McDonald's cards.
Yeah, I think the COVID epidemic is going to show that in some cases, well-structured incentives can work really well. So there is a hope in the contingency management field, which is part of what they're doing up in Vermont, that they can leverage some of the data for that to show that health behaviors can be effectively changed for a relatively small amount of money. Hopefully. It'll take a while though. So in the meantime though, Bill, applying for specific grants that would support that research is one mechanism to do so. Not an easy one though.
Do we have any other questions? Again, feel free to unmute yourself or put it in the chat.
Hi. I think I have more of an observation than a question, just something to think about. I think that as I was listening and as you started out, I was really thinking about how like the focus about contraceptives and sexual reproductive health is really focused on women and women making sure that we're doing what we have to do to make sure we're not getting pregnant, and just wondering more about work that's been done to think about sharing in that with men and men also taking the responsibility, which I feel like is such a huge piece in terms of socialization of sexual behaviors. But I guess I just wanted to pose it as a question first of maybe some more sexual health information for men in terms of contraceptives, but also just something to think about in terms of this.
No, definitely. And is it Anne-Marie? Is that your name?
No, my name's Rena.
Oh, Rena, sorry.
It's
cropping it weird on my screen. No, thank you, Rena. And that's a really, really good point. We actually do have some data that is unpublished at this point, but it does talk about that negotiation for contraception. And our group is actually the first to study knowledge across men and women, which is really cool. We're having a little bit of a hard time getting it into a journal this summer, but to your point, one of the things that Andre and Mishka and I really looked at initially was we're only talking about women whenever this research is being done. And that's obviously missing a massive part of the picture. So unfortunately, we're the first group to like look at men, but you don't know we have because we don't have any of that data published yet. But one of the things that we showed in it is that men have a lot less knowledge about contraception than women, which makes a ton of sense because it is so focused on educating women and putting that onus on women that's not appropriate by any means. And so what we then took a step back and did was talked about how the decision-making processes happen. And what's interesting, as you would imagine, or as you might imagine, there are really big differences between how men and women view the contraceptive negotiation, so to speak, where men think that it's their choice, women think it's their choice, or a conversation point. And what we found is that part of the issue there is if we're not providing evidence-based contraceptive counseling to men, and men expect it to be their choice, then they're not necessarily going to make the best decision, right? Because they have no idea that these LARCs even exist in most cases. So it's wholly inefficient to just focus on women when we're doing and implementing the reproductive and sexual health services in the clinic. And I hope I illustrated that, and our research shows the same thing. Men are interested in and experiencing issues with erectile dysfunction and with premature ejaculation. And so leaving them out of it can be really a disservice to all patients in the clinic. But it also does perpetuate what you're saying, Rena, which is that this expectation that it is the woman's responsibility. And I do hope that my talk did not further reinforce that. I think we're a bit limited by the existing literature that I tried to say at the beginning. And so much of it's focused on that unintended pregnancy rate that almost all of it's also focused on getting women to use high efficacy contraception. And I think, as you pointed out, that is deeply problematic in a number of ways. And so overall, providing a holistic, both men and women approach to integrating care is the best outcome. Does that answer your question?
Absolutely. Thank you.
Sure. It was a really great point. And sorry that my talk went down that way.
Oh, no, I think it was partly because I had just seen a New York Times article about talking about sexual health with young children and how we don't talk about it soon enough. And how, yes, it can feel awkward and kids can do awkward things, but by not talking about it to boys and girls, we're not giving them the tools, just as you said, to make informed and appropriate decisions or healthy decisions. So thank you.
You know, it's absolutely right. And one of the tricky things that there's good data to suggest is people generally think the contraceptive approach they're using is the highest efficacy approach, regardless of whether or not it is. And so awareness or knowledge of an approach kind of nudges up their perception of its efficacy. So men traditionally think, because they're not familiar with the actual high efficacy approaches, that's part of why they also use some of the lower efficacy approaches, is because they think they're really high efficacy, because we haven't had those conversations. So it's a really unique conundrum, one that I hope can be at least addressed partially by providing that evidence-based information to both groups of men and women. And that's really important, at least a step in the right direction, hopefully. Thank you for that point, Rena.
Do we have any other thoughts or questions?
Oops, sorry.
Okay, well, thank you everyone for joining. We will be sending out an email. Jonathan, it sounds like we'll have these slides that we can include in the emails that we send to the attendees.
Sure, if you'd like.
Be great, thank you. And thank you everyone for joining.